Hi everyone, this is Candice, and I'm here to show you my case. Alright, so I did my placement at Osnum Hall of Queens, which is in Bayside, Queens. I know a lot of you might have been there for dysphagia class with Dr. Kolodny, but for those of you who are not familiar with the facility, here is a little information about them. So they were founded in 1971, and as stated by their website, it's guided by the Carmelite mission to bring dignity and quality of life to the care of seniors. And Osnum Hall provides both short-term rehab and skilled geriatric care for approximately 432 residents. Alright, so I chose an older woman that came in February, and Nikki and I actually did the eval together with Dr. Kolodny and with our supervisor Tiffany. So IR is a 96-year-old woman who was admitted to Oz and evaluated on February 1st. The reason for referral was that she had a left middle cerebral artery stroke, aphasia and dysphagia. So we were called to rule that out. So her medical diagnosis, so primary diagnosis was the CVA, which was ischemic, and like I said, it was left middle cerebral artery, and she had right-sided weakness. And secondary diagnoses were hypertension, AFib, Wernicke's aphasia, and hyperlipidemia, which pretty much is just that she had high cholesterol. Alright, and additional information, so she does wear bifocals, and she had natural teeth, and she had no history of hearing impairment. So the treatment diagnoses, so she had aphasia following the cerebral infarction and dysphagia unspecified, and so those were the ICD codes next to it. And then for therapy, so she did have previous therapy at other facility, and then now we took her on for therapy. So we took her on and did therapy for 5 days a week, for aphasia and for oral pharyngeal dysphagia. And her current diet was mechanical soft with thin liquids. Alright, so she had Wernicke's type aphasia. So Wernicke's type is an impairment that's in the use of language, expression, and comprehension of language and any modality, and it's caused by an acquired form of brain damage. The most common cause of aphasia is a stroke, as we all know, and in Wernicke's aphasia, there's a lot of damage to or near Wernicke's area, which causes impairments in auditory comprehension, normal articulated, they do have normal articulated speech, and fluent productions of inappropriate words or speech sounds. So the acronym which I had on the previous slide, HTN, was the hypertension, or high blood pressure, HDL, which is hyperlipidemia, which is cholesterol, and then she had AFib, which is irregular heartbeat. Alright, so here's a little background information. So Miss IR was living on her own. She was living independently in the community. She was well traveled, and she took care of all of her own finances. Her support system was mainly just like her friends and her church family. She has no existing family, unfortunately, with the exception of a distant cousin, but her distant cousin did not live that close, so mainly it was just her church family. In terms of education, she had a high school education, and she did take some college courses. In terms of work, so she was an office manager, and then in the church she was in charge of the financial affairs. So she was very involved in her church, and again for community, so she was extremely involved in the church, and she was in charge of the financial affairs of the church. So her initial assessment. So she was seen for a speech and swallowing evaluation where we measured her informal language across all modalities. of language to accurately try and assess her function level across the modalities. She presented with Wernicke's like aphasia and was able to follow simple one-step commands and was able to respond appropriately to some questions relating to biographical and explicit information. Her verbal output was often compromised by perseverative errors, verbal paraphasias, neologisms, and word-finding deficits, as well as paragrammatic speech. And she was able to match written words with pictures in like a field of 3, but overall her awareness in terms of like self-monitoring and repetition were considered pretty poor. Like she would continue to perseverate on the word parade. Like everything that she said, it was always the parade, the parade. So we would show her a picture and she would say, oh, well, they're going to the parade, or she has a parade. So she was just stuck on that one word, parade. We also did a swallowing evaluation, so we gave her a cookie, and she did demonstrate adequate by force mastication, oral organization, transport, clearance, and timely swallows for hard chewables. So, and then we did an oral motor exam during treatment. Alright, so in terms of our initial treatment plan, so based off of her history, we decided that it would be appropriate for her to be placed onto therapy, and we decided to put her on to one-to-one restorative therapy 5 times a week for 8 weeks. So since she did live independently, our goal was for her to just become a more reliable communicator, considering she, was in charge of her own affairs in the past. So for her long-term goal, we decided to make it for her to become a functional and reliable communicator and candidate for the highest level of diet consistency, since she was on regular food in the past. For short-term goals, we came up with a lot of the goals were expression, obviously. So we had naming, so she would have to name functional objects or actions to 40% accuracy with multimodality cueing. So for identification, she would have to identify functional objects and actions to 40% accuracy with multimodality cueing. And then verbal formulation, so she had to provide one salient comment in response to a functional thematic presentation to 40% accuracy with max cues. And then verbal production, in which she had to respond appropriately to biographical or like simple explicit questions to 40% accuracy. So for instance, with the naming, we would show her a picture, and then let's say it was a picture of an apple, and then we would ask her, okay, what is this? Like, what is this called? And then we would wait for her to respond. For the identification, oftentimes we had it in a field of 3, so we would have 3 pictures laid out in front of her, and then we would pick each one up, like, one at a time, and just show it to her up close and say, okay, did you look at this picture? Did you look at all the pictures? And then as we were saying that, we would move our hands across the pictures to make sure that she was following, like, the images that we were looking at, so that when we would ask her questions, she was attentive and did focus in on what it is that we were trying to ask. And then in terms of the goals, we did progress notes every 2 weeks, so we were able to assess what she was doing and then upgrade her goals as needed. Okay, so some of the changes in her goals were that, like, so for instance, like, she upgraded her naming. She did very well. She upgraded to 60%, but then oftentimes it was kind of challenged by her perseverations and neologisms, etc. Identification, she improved drastically, and she ended up at 80%, which then also was eventually discontinued or DC'd. Verbal formulation was upgraded, and then we upgraded it to having her make 2 comments, and then we changed the cueing to moderate and then to minimum until she didn't need any more. So, like, she would still need some cueing, but it was minimal, especially compared to how it was when we first initially met her. And then verbal production was also upgraded, and then upgraded to conversational level, and then DC'd. We also added some new goals. So one of them was to trial her with modified regular foods, solids, and then once she was able to safely and efficiently eat the modified regular food, we upgraded her diet and discontinued that goal. Then we also added a attention retention recall goal, where we would read like a short little sentence and then ask her questions about it. So let's say John went to the train station at 5 p.m. What time did John go to the train station? So then the answer would be 5 p.m. And then we also added a reading comprehension goal, in which she would read a sentence to herself, and sometimes we would also read it out loud and have her follow along with us. And then we would have 3 options for the answers, and so she would have to either point or tell us what the answer was. Oftentimes she would just point to which answer she believed the correct answer was. Okay, and then some of the goals, as you saw, were not upgraded because of the fact that they were occasionally challenged by perseverative errors and neologisms and paraphasic errors. So like I mentioned before, she would say like the parade for everything. And then we did give multimodality cues and graphics. So sometimes we would use pictures that were in her room and ask her questions about the people in those pictures or what she might have been doing. Overall, I do think that the goals were appropriate. And I say this because we saw a lot of improvement in how she was when she first came in compared to how she was just like last week. Granted, we took her off about, I want to say like almost a month ago now, but we've seen so much progress, and it's really amazing to just see what we were able to accomplish with her. And again, if the goals were no longer appropriate, we would always upgrade them. So even if the progress note wasn't due yet, if we noticed that she maxed and was just doing great, then we would change the Q level or change the field. So if we were doing field of 3, then we would change it to field of 6, just to make it more challenging and just make sure that it was always appropriate to her level. Yeah. Okay, so for discharge and treatment results, so we noticed that there was an increase in verbal formulation and production, and this was evident based off the decrease of paraphasic errors, like I mentioned, decrease perseverations, neologisms, and there was an increase in spontaneity in terms of expressive language. So when she would see us sometimes in the hallway, she would say, "Oh, like it's you, you're coming to get me," and whereas before she wouldn't say this at all, you know. Her diet was upgraded, as I mentioned, and we just noticed the overall improvement across all of her goals. So in terms of billing, so I have all the G codes here and then the functional levels. So for some of the goals, you know, I would consider her impaired to about 40%. So then you see that here. And then all of the ICD codes are on this side. So cerebral infarction, aphasia following cerebral infarction, facial weakness, muscle weakness, and dysphagia unspecified. And again, for the G codes, I have the spoken language, which is what we tested her on initially. So that's why I included that. Spoken language expression, which we worked on. So we tested her, we worked on it, we discontinued it, and she left for treatment because she's off of our caseload now. And then the same thing for memory. So this has to do with the attention retention recall. Swallowing. So again, we tested her or evaluated her first, and then put her onto therapy and then discontinued it. And then the same thing with reading comprehension. And that's it. So thank you for watching. Bye guys, and have a great summer. It's been lovely working with every single one of you, and I can't believe we're graduating. So congrats, we finally did it. Yay.